नॉर्मल जो ऑडिबल साउंड है that is between 20 hertz to 20,000 hertz. That is your audible sound. Below this is infrasound and above this is ultrasound. So we will study this part, and it is not audible to human ear. We can't hear it when we are doing USG of the patient. If it was audible, so we will get disturbed with the sound. Obviously, we will not be able to do the procedure. It is not audible ultrasound. Now, what is the basis of the machine? So, ultrasound. So, there is electricity. This is the machine. It has some crystals. And this is your object. So, in the machine there are some piezoelectric crystals. What do you mean by piezoelectric? Piezo means pressure, electricity means electricity. When electricity comes in the machine, it causes the crystals to vibrate under pressure. They vibrate and they produce sound waves or ultrasonic waves. They produce ultrasonic waves which reaches the object, and some of the waves passes through and some of the waves reflects back, or you can say get echoed back. The echo word is used in terminology of the ultrasound. It gets reflected back or echoed back. So, whatever sounds or waves come back, it is analyzed by the machine and the image is produced according to that. If the waves comes from near object, the image will be different. If waves come from the farther objects or deeper objects, the image will be different. Okay. So, according to the depth, the image is different according to the echogenicity of the object. Now, coming on to the what do you mean by echogenicity? Normally, three terms are used in whenever you describe an image, USG image, three terms are used. Anechoic, hyperechoic, and hypoechoic. What is echo? You are standing on a mountain, you utter some shout some word and the words get echoed back, they comes back to you, that is the echo. The same applies to here. Anechoic means there is no echo, nothing is coming back, everything is getting absorbed or passes through the tissue. So, anechoic appears as in USG, it appears as black. Okay. Black means anechoic. What are the structures that appear black? That contains fluid. That means bladder, urinary bladder contains fluid. So, bladder. How many bladders do you have? How many bladders do you have? Bladder, any cyst, simple cyst containing fluid, or any cavities, You have two bladders. Which is the other bladder? One is gallbladder. Very good. Gallbladder appears black. Whenever you will see liver is hypoechoic, and inside that or after some tissue of the liver there is gallbladder, that is blackish. That is the second bladder, gallbladder. Now, hyperechoic means there is anechoic means no echo, no echoes, Hyperechoic means high echoes, or everything gets reflected back. So it appears as white. Hypoechoic means everything is coming back, everything is echoing, coming back, reflecting back. That gives the white image in the USG. What are those? Stone and bone. Heart structures that are stone and bone in the body, stone and bone. Hypoechoic is in between these two, in between. That appears as grey. Other structures like liver, like kidney appears as grey. There are different 256 grey shadows are can be processed in a USG machine, normal USG machine. So this is the basis. According to this, we will analyze the USG. Suppose in a bladder or anechoic structure, suppose this is urinary bladder, this is blackish. Nothing is getting reflected back, everything is passing to the deeper tissue. That is why it is good acoustic window. Good acoustic window. Acoustic window means that gives good image of the deeper structures. Or bad means suppose a gas is there, bowel gas is there, that will hamper the image quality of the deeper tissues. So bladder or any fluid acts as acoustic window. Liver is good acoustic, good acoustic window. Spleen also good, acts as good acoustic window. Suppose in this black or anechoic region there is a stone, bladder stone. How it will appear? Appear as white. Hyperechoic, that is stone, hyperechoic. But what will be the below structure? Below structure will be appear as black, because the waves are not able to pass through this stone. This is acoustic shadow. Acoustic shadow. So same thing, if the gallbladder is there, there is a stone or GB stone. This is anechoic, that is black, and this is white, GB stone. The below will be acoustic shadow. This will be acoustic shadow. Now coming on to the probes, normally we use three types of, normally two types of probe in obs and gynae. One is curvilinear probe, okay. This is low frequency, curvilinear or curved probe. This is normally used in transabdominal sonography, TAS. What happens is any sound waves consist of this amplitude, this is amplitude, there is wavelength, this is wavelength, this frequency. So frequency, how many cycles repeated in a second. So that is frequency. So there can be high frequency, low frequency ultrasound probe. This is low frequency. What happens in low frequency ultrasound waves? Low frequency gives less resolution but deeper penetration. Resolution will be less resolution. The picture clarity will be less resolution and deeper penetration. And the normally that we use in transvaginal sonography, that is the intracavitary probe, that is high frequency. High frequency is more resolution or better resolution, and but not deeper, shallow penetration, less penetration, more resolution. Okay. Or same applies to the linear probe also. Linear probe is high frequency. This is linear, this is high frequency. So normally in obs and gynae we use this for transabdominal and intracavitary for TVS. Transrectal also can be done with this intracavitary. What are the other fluid structures in the body? apart from bladder, cyst, heart, yes, blood and vessels. So you can do USG of the vessels also. We do color Doppler of the vessels, so that can also be done using USG. Now coming on to the imaging. You will just see the image, how the normal image appears and what are the normal structures seen in the image. Don't go into theory part, already I have told you in the short. Whatever you need to know, I have already told you. Normal frequency is 2 to 15 megahertz in the USG. Same lower frequency gives greater penetration and higher frequency allowed to see more details or better resolution. This is the convex, this is the linear and this is the intracavitary. This is a transducer, ultrasound waves goes and touches the object and gets reflected back, and the received is pulses analyzed in the machine and images produced. What happens in X-ray? X-ray, when the patient is lying down, the X-ray goes and there is a plate below. The plate receives the X-ray, but in USG the sound waves reflects back and the same machine analyzes the waves. But in X-ray there is a plate that receives it. Ultrasound is no substitute for a good history and thorough clinical and general examination. Okay. Investigation, at MBBS level normally you need to know the history in detail, history and examination. You can diagnose approx 80% of the diseases by just clinical history and good examination only. You don't need investigation reports. Less 20% to 30% you will need reports. The transabdominal, transvaginal, Doppler ultrasound, tissue harmonic imaging, 3-dimensional ultrasound. In transabdominal, full bladder is required because that occurs access acoustic window, good view of the deeper tissues. But in transvaginal, empty bladder is there because the probe is near the cervix. You don't need this is the uterus, this is the cervix and this is the vagina. The probe is here. Probe is just near the structure, near the organ. Probe is there. You don't need bladder in this case. So, whatever structure is, this is the abdominal, this is the bladder and here is the uterus. Okay. And here is the probe. So, whatever structure is near the probe will appear on the top of the image. Whatever structure is near the probe will appear on the top of the image. You have to remember this when you are seeing the transvaginal sonography and when you are seeing the transabdominal sonography. So, in transvaginal sonography, empty bladder is required because you don't need bladder as an acoustic window. Here you can see uterus, ovaries, follicles, pouch of Douglas and any gynec diseases. This is the normal appearance of the uterus. This is the bladder, this is the anechoic structure, this is the bladder above, this is bladder, this is the uterus, okay, and this is the endometrium. These are the ovaries, right ovary and left ovary. This is the transverse section. Okay. Probe is kept like this, Probe is kept like this, so you will get this kind of. You are just transversely seeing the structure of the ovary and uterus. This is the vertical. You are keeping the probe vertically. So you will get the longitudinal sagittal view of the structure. This is the uterus, this is the endometrium, this is the cervix, and this is the vagina. You are doing the TVS, uterus is anteverted and here retroverted. Opposite direction of bladder and this is same direction of the bladder. What is this? This is transabdominal sonography or transvaginal sonography? Transabdominal ki transvaginal? What is this? What is this? Transabdominal, transvaginal. What is this? This is transabdominal. You can see the bladder here. And uterus is not that clear in transabdominal sonography. This is transabdominal. You can see bladder here. After bladder only you can see the uterus. This is transvaginal because you can't see. This is the probe, and the first structure you can see is the uterus and the cervix. This is the cervix, this is the uterus. This is the endometrium, endometrial cavity. This is the uterus, this is the cervix. What is this? This is transabdominal sonography. This is the bladder. So, to diagnose any uterine mass, you can, or any to diagnose any AUB, abnormal uterine bleeding, you can do ultrasonography. There are the indications. These are the indications: congenital anomalies, myomas or uterine fibroid. These appear as hypo, iso or hyperechoic. This is myomas appearance is slightly variable, but it will be different from the normal myometrium of the uterus. Adenomyosis, enlarged uterus, asymmetric thickening of the myometrium, and heterogeneous ecotexture of the myometrium will be there. And the endometrial myometrial junction will be hampered, okay, in the adenomyosis. You can't clearly see the endometrium. And in myomas, it will be different echogenic masses, different size, number, location will be there. And due to that, there will be irregular uterine contour. Congenital anomalies, bicornuate, septate, didelphys can be diagnosed by using USG. But to confirm the congenital anomaly, you will need to do MRI and even laparoscopy. So, abnormal uterine bleeding like polyp, submucous fibroid can be diagnosed. Postmenopausal bleeding, very important, you have to do USG to see the endometrial thickness. If it is more than 5 mm in postmenopausal patient, it needs evaluation. Endometrial cancer, to see myometrial invasion, tamoxifen therapy to see thick endometrium or any subendometrial stromal vacuolation. Missing ICD, very important, you can you will be given in exam X-ray or USG. The ICD will appear as bright echogenic structure. It is slightly. So, you can see the if there is any penetration in the endometrium or myometrium or any translocation to the peritoneal cavity. Earlier we used to do for missing ICD, we used to do X-ray, we used to advise, but nowadays USG is sufficient to diagnose missing ICD, location of the missing ICD. This is the anomalies of the that was taught in different class. So, this is bicornuate uterus, 2 endometrial cavities you can see. This is didelphys, 2 uterine cornua can be seen. This is the septate, this is the F and this is the C. If F, the distance from here to here is less than 2 cm, this is incomplete septum or partial septum. If the distance from this to this is more than 2, that is complete septum. This is the submucous fibroid. These two also are fibroid. This is the fibroid. This is also fibroid, this one. This is the fibroid. Here, this hypoechoic structure is the fibroid. This is the uterus and this is the fibroid. You can't see in every picture, it is not that clear, but approx idea you can get. So, this is the uterus, this is the cervix and this is the pedunculated fibroid. This is slightly hypoechoic. This is the pedunculated fibroid. So, loss of endometrial myometrial junction when seen on images. There is you can't clearly see the, this is the uterus, but you can't clearly see the endometrium. You can't differentiate where is the myometrium, where is the endometrium. And there can be cystic vacuoles in the endometrium. It is characteristic of adenomyosis. This is adenomyosis and this is posterior wall adenomyoma. Posterior wall adenomyoma. This is the missing IUCD. You can see IUCD. This is hyperechoic structure, linear structure in the endometrial cavity. This is the IUCD. It is in normal position, okay, normal position. This is the myometrium, this is the endometrium, it is normally placed. Normally placed. This is in the myometrium, okay, this is penetrated. This is in the myometrium. This is the transverse section, this is the longitudinal section of the same patient. And this is penetrated and this is in the myometrial wall. This is the IUCD. This is in the cervical region. This is the cervix. The IUCD has come in the cervical region. Misplaced IUCD. Here this is the this is not that clear, but this is the bladder. This is the uterus. This is the uterus, and IUCD is in the bladder wall. So IUCD has gone penetrated into the bladder wall. This is perforated. It has, this is the uterus on outline. This is the uterus. This is the cervix. This is the endometrial lining, and the IUCD has perforated outside the myometrium. This is the myometrium, finishes here, and the IUCD is beyond this point. That means it has perforated the uterus. Now you can also see fallopian tubes. Fallopian, different pathology of the fallopian tube in the USG, like hydrosalpinx and hematosalpinx, piezoelectric, and which identical pathology you can see? Ectopic pregnancy, very good. This is the confirmatory or diagnostic in case of ectopic pregnancy, USG. This is the hydrosalpinx, the tubes are enlarged. This is the hydrosalpinx, this is the ovary. Don't get confused ki earlier you were seeing uterus here, now you are seeing the tube here. You have to see the placement of the probe, where the probe is placed. You have already seen the uterus, then you are going laterally, you will see the tubes and ovaries, okay. So according to the probe localization, you will see the structure. This is the hydrosalpinx. This is the, earlier it was anechoic. This is anechoic, filled with fluid or liquid, but here it is filled with blood. That is why it is echogenic homogeneous material, okay. This is hematosalpinx. Same appearance appears in the, if any endometrial, which pathology? Chocolate cyst, or and which cyst? Endometriotic cyst or chocolate cyst. You will appearance will be same like this. It is known as ground glass appearance. This is piezoelectric. Echogenic debris you can see, dot 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 you can see in the lumen, it is suggestive of pus. This is piezoelectric. This is normal ovary, and this is the uterus. This is the follicles in the ovaries. This is the premenarchal appearance, small uterus and cervix and vagina. This is premenarchal. Small multifollicular ovaries, these are the follicles, and this is unilocular, one locule is there. This is the endometrium. So here you can see the follicles, and this is the dominant follicle. This is the polycystic appearance or morphology. You can see what is this? This is known as, this is normal, and this is PCOS. What this is known as? Pearl string appearance. Very good. This is the MCQ, pearl string appearance. A different pathology, why it occurs will be taken in the your class, lecture class. This is a typical appearance, pearl string appearance, string of pearl appearance or pearl string appearance on the USG. This is the pearl string appearance. Like a woman is wearing a necklace of pearl, that is the same appearance. Earlier it was say 12, but nowadays it is 16. This is ovarian hyperstimulation syndrome, ovaries enlarged. You cannot see particular single follicle, multiple cystic structures will be seen in the single ovary. This is ovarian hyperstimulation syndrome. It mainly occurs during induction of ovulation induction. Mostly earlier we used to get these kind of patient when we used to give clomiphene citrate as a induction ovulation induction drug. The side effect was OHSS, that is ovarian hyperstimulation syndrome. It is very deadly syndrome actually. This is world spoke appearance, bilateral enlargement. Now coming on to the dermoid. Dermoid, there are typical some findings like there is Rokitansky nodular dermoid plug, that is the calcified, or there can be bone, there can be tooth, or any echogenic structure will be seen or nodule will be seen, that is known as Rokitansky nodule, that is characteristic of dermoid cyst. Okay. And other will be echogenic, shadowing, calcific or dental tooth components. There can be fluid fill levels, there can be hypoechoic structures, there can be dot and dash pattern, multiple thin echogenic bands caused by hairs in the cyst can be seen, and there will be variable appearance of the dermoid cyst due to presence of fat, fluid, hair, bone, tooth. There will be different appearance of the different part of the dermoid cyst, but characteristic is Rokitansky nodule or dermoid plug. There is one more appearance, that is a tip of iceberg signs. It is due to sebaceous material or hair calcified material seen within the cyst that causes this tip of iceberg sign. Behind this structure there will be sono-opaque or dark. Behind this structure this is dark. You can't see structure beyond this point, this is the shadow. This is the Rokitansky nodule. This is theca lutein cyst. In which disease or which pathology theca lutein cyst is seen? Molar pregnancy, very good. Mostly in molar pregnancy it is seen. Theca lutein cyst, bilateral theca lutein cyst is seen. Here theca lutein cyst. The ovary can get enlarged up to 15, 16, 20 centimeter also. Okay. And whenever the beta CG falls, the ovary will come back to normal size on its own. This is the corpal luteal cyst. This is ground glass appearance, it is endometrioma or chocolate cyst. Blood is filled inside the cyst, that is chocolate cyst. Now coming on to the OBS USG. I will tell you in the short what we see in the first trimester. Why do you do USG in the first trimester? First you want to confirm that pregnancy is there or not, what is the location of pregnancy, what is the dating, what is the age of the pregnancy, what is the gestational age of the pregnancy. So you have to confirm the pregnancy, whether it is viable or not, heartbeat is there or not, what is gestational age. You have to rule out ectopic pregnancy, you have to rule out molar pregnancy, you have to rule out any foreign bodies. If large for date is there, you have to see for fibroid, any uterine malformation is there or not, multiple gestation can be confirmed in the first trimester only. Missed abortion, blighted ova. To see any suspected complication like subchorionic hematoma or hemorrhage. In the second and third trimester, you will confirm the viability, you will confirm the gestational age, you will see the fetal number, whether twin pregnancy, triploid is there. Evaluate fetal growth, anatomy, lie, position, follow up, evaluate the placental location, amniotic fluid volume, the location of the cord, biophysical profile for fetal well-being, and in case of vaginal bleeding, you will rule out the pathology of the bleeding. In the second trimester, you will do the survey of the fetal anatomy, that is anomaly scan is done in 20 weeks, at around 20 weeks, that is anomaly scan or level 2 scan. And in the first trimester, CRL is seen, and in the second, third trimester, BPD, head circumference and abdominal circumference, fetal femoral length is seen in the third trimester. So, this is the first trimester USG, this is the G-sac, here you can see the embryo, this is the yolk sac. This is the double decidual ring is a characteristic of the intrauterine pregnancy, and you can see the yolk sac, ring like structure, this is the yolk sac. So, first the appearance will be G-sac, first appears the G-sac, then comes the double decidual ring sign, then comes the yolk sac, then comes the embryo, then comes the heartbeat or cardiac activity. This is the sequence. At around 4 weeks, your double decidual sign will be seen, 4 to 4.5 weeks, and yolk cell will appear at around 5 to 5.5 weeks, and your embryo will appear around 6 weeks, cardiac activity appears around 6.5 to 7 weeks. All the findings appears earlier in the transvaginal sonography and later in the transabdominal sonography. This is the yolk sac, this is the embryo, this is the twin pregnancy. 2 G-sacs you can see, 2 embryo you can see. And one more USG is done in first trimester at around 12 weeks, that is nuchal translucency scan or NT scan. You will see the fluid in the neck area or nuchal translucency, you will measure this area. Okay. It is more in which cases? More than 3 mm, suppose it is more than 3 mm, in which case? In aneuploidy, like trisomy 21, that is Down syndrome, trisomy 13, trisomy 18, Edward-Patau syndrome. How you will measure the crown rump length? You will measure from head to bottom, okay? Crown to rump length, that is measured in the first trimester. You will, how you will measure the gestational age? By measuring the CRL, okay, in the first trimester. How you will measure the gestational age in the second trimester? By measuring the BPD. Biparatal diameter. How will measure the gestational age in the third trimester? BPD or SC? FL, femoral length is used in the third trimester. Okay. So, here you can see the baby, this is the fetal head, this is the fetal spine, this is the CRL, crown to rump length. This is what? Triplet. This is the G-sac, this is one G-sac, and this is the third G-sac. Here you can see small amount of hemorrhage, subchorionic bleeding. This is the twin pregnancy, one G-sac, another G-sac, 2 embryos are there. This is how you measure the amniotic fluid, the dark area. You have to measure the amniotic fluid in the 4 quadrants, and then you do the sum, then whatever comes is the AFI. You can also see the cardiac structure, fetal cardiac structure in the USG. This is the cardiac structure. Fetal age estimation in second third trimester, use the BPD. For BPD there is a particular, you can't measure the BPD at any level of the fetal skull. You have to measure at particular point. What is the particular point? This one. There should be falx cerebri should be visible. There should be cavum septum pellucidum should be visible, and thalamus, bilateral thalamus should be visible, and choroids should be visible. In that plane, at that plane the BPD is taken. Here you can see cavum septum pellucidum, this is the thalami, and this is the falx cerebri, and this is the your choroid. So, at this level BPD is measured. From this to farthest point you will take BPD, and you can also measure the head circumference at this level. Femoral length of the femur, farthest point. Abdominal circumference, where you will measure the abdominal circumference. From at that point there should be spine visible, should be there should be ribs, there should be vein, portal vein should be visible, and there should be stomach bubble should be visible. Okay, at this level you will measure the abdominal circumference. How the circumference is measured? You will just put a pointer over here, and the machine automatically takes the circumference according to that. You do not have to calculate by mathematical formula. This is the umbilical vein, this is the spine, this is the stomach. Now coming to ectopic pregnancy, this is the adenexa, you can see a G-sac and embryo there, this is the ectopic pregnancy, and uterus will be empty. and the G-sac will be in the adnexa. This is ectopic pregnancy. This is ectopic pregnancy. This is the uterus. This is ectopic pregnancy. This is normal uterus. This is the ovary. This is molar pregnancy, snowstorm appearance, and very high beta Hg is there, and thecolytin cyst are there. This is this molar pregnancy. So, this is the picture of molar pregnancy, snowstorm appearance. This is the one X-ray of missed copper T. This is the two heads, fetal head. This is twin pregnancy. This is the cervix. This is the placenta, low-lying placenta. This is the BPT. This is twin pregnancy. Two G-sacs can be seen. This is fetal head. Any abnormality can you see in this picture? It is overlapping. It is IFD or Spalding sign. In UAG machine, there are different modes: B mode, M mode. B mode is for brightness, M mode is for motion. M mode is used for measuring the fetal cardiac activity, fetal heart rate, and for the movement of the fetal or valves of the heart, doing echocardiography. That's why UAG can be used for fetal echocardiography also, and normal echocardiography also. UAG can be used.